Well, hello everyone. Thank you for joining NeuroTalks today. I think people are still joining us, so I will just wait 1 or 2 more minutes. Well, meanwhile, just let me introduce you to the topic of the lecture of today. Today, NeuroTalks is slightly different from what it has been. Today, it's a NeuroTalks tutorials. It means that I'm going to address the basics, the essentials of interventional neuroradiology, and in this specific case, I'm going to talk about anatomy of the external carotid artery and its dangerous anastomosis. So we all know that anatomy is very important. The external carotid artery anatomy is also very important because the connections between the external carotid artery and other systems, they do exist, and specifically with the internal carotid artery. And of course, the problem is that those connections between the external carotid artery and the internal carotid artery can be very, very dangerous and can result in deficits for patients when they are being treated. So having said that, I think we are almost all together, so I will just start the presentation. Thank you for joining. So I'm going to talk about the normal adult anatomy of the external carotid artery. Of course, it's impossible to talk about the dangerous anastomosis with avoiding the subject of embryology. I'm going to address that very lightly. And then the main routes for dangerous anastomosis between the external and internal carotid artery. So anatomy. We all know that the arteries that go and supply the head come from the carotid artery and the subclavian arteries. The carotid arteries and subclavian arteries have different morphology on the right and on the left side. On the right side, we have a common trunk that gives the right subclavian artery, and then another vessel that is the common carotid artery on the right side. Then on the left side, there is an independent origin of the common carotid artery on the left, and usually independent origin of the subclavian artery. And the vertebral arteries are usually coming from both subclavian arteries. Of course, on the left, sometimes, and this more often, seen the vertebral artery coming from the arch. The external carotid artery, as we know, is one of the branches of the common carotid artery, and it passes forward and upward, slightly inclining backward, and then gives 2 terminal branches, the superficial temporal artery and the internal maxillary artery. The branch of bifurcation of the common carotid artery happens at the level of C4 and has very strict relations with the nervous structures and with the muscles of the neck. It is also related with the internal carotid artery in the posterior aspect, as you can see here in this figure. On the CTA, we can see that the internal carotid artery is actually posterior to the external carotid artery. And also, the vertebral arteries are also seen here in their usual route, and the internal jugular veins are posterior to the internal and external carotid artery. Then the external carotid artery has 8 branches. 3 that are in the anterior aspect of the external carotid artery, 3 on the posterior aspect of the external carotid artery, and then the 2 terminal branches that I have already mentioned. Regarding the branches, we know that the external carotid artery gives 3 anterior branches And the first one is the superior thyroid artery. And on the anterior aspect, the second artery is the lingual artery, then the facial artery. On the posterior aspect of the external carotid artery, we have the ascending pharyngeal artery, the occipital artery, and the posterior auricular artery. We are going into details of all these branches. And then the final branches, the terminal branches of the external carotid artery, the internal maxillary artery, and the superficial temporal artery. So let's go deep into these all arteries. The first of all, the first one that happens on the anterior aspect of the external carotid artery is the superior thyroid artery. And the superior thyroid artery has 4 branches: the infrahyoid artery, the superior laryngeal artery, the sternomastoid artery, and some terminal gland branches to the gland itself. Also, there is another branch that is the cricothyroid artery. Why is so important to know the anatomy of the superior thyroid artery? Because we know that the thyroid is also supplied by the inferior thyroid artery. So it might happen that the superior thyroid artery and the inferior thyroid artery can at some point share the blood supply, and if we are doing some kind of embolization of the superior thyroid artery, we can actually reach the inferior thyroid artery. And why is that important? Because the inferior thyroid artery is a branch itself of the thyrocervical branch of the subclavian artery. And we know that the subclavian artery gives a branch that is the vertebral artery. It's true that the vertebral artery is proximal to the origin of the thyrocervical trunk, but even so, we need to know, and we need to have it and keep in mind that embolizing the superior thyroid artery for any reason might at some point be dangerous, because there are anastomosis with the posterior circulation that goes into the brain, into the encephalon. This angiogram here shows that the superior thyroid artery also can origin from the common carotid artery, and it happens in about 10% of the cases. The lingual artery is the second artery coming from the anterior aspect of the external carotid artery. And the main branches of the lingual artery are the dorsal lingual artery, and also the small suprayoid artery, the deep lingual artery, and the sublingual artery. You might remember that we have just said that the small infrahyoid artery is the first branch of the superior thyroid artery. So again, the superior and inferior hyoid arteries going to the same region. Here an angiogram showing the dorsal lingual artery, the small suprayoid artery, this branch here coming in very proximal in the track of the lingual artery, and then the sublingual artery, and then the deep lingual artery. There are 2 important notes that I'd like to share with you regarding lingual artery. The first of all is that embolizing the deep lingual artery is dangerous, because there are no connections to the other half of the tongue. So it means that if you are embolizing the lingual artery on one side, there is no way of having supply from or contribution from the other side, and that might be very dangerous and causes necrosis of the tongue. So lingual artery is also something that we need to be very careful when we want to manage that. The facial artery. The facial artery has cervical and facial branches. The cervical branches are the ascending palatine artery that you can see on this image here. And then we have a tonsillar branch, then we have the submental artery, and then we have some glandular branches. Something important, if you are going to embolize any kind of lesion that is supplied by the submental artery, you need to understand that you need to go distally to the origin of these glandular branches to avoid the necrosis of the gland. So another important situation that we need to be careful with. Also, the facial artery with the cervical branches has anastomosis with the maxillary artery. So there are external carotid anastomosis. And here is the ascending palatine artery anastomosing with the descending palatine artery from the internal maxillary artery. Then we have the facial branches of the facial artery. And here we have the upward track of the facial artery, giving the inferior and superior labial arteries, then continues with the lateral nasal artery that goes into the region of the nose and to the medial aspect of the orbit, giving the angular artery. And as we are going to see again, the angular artery is might anastomose with the dorsal nasal artery from the ophthalmic artery. So the facial branches of the facial artery are a potential route for getting access to the internal carotid artery through retrograde flow. So this is an important anastomosis between the external and internal carotid artery. Then we have here an angiogram of the facial artery, where we can see the ascending palatine artery here, the first branch, then the submental artery, and then the facial branches of the facial arch, so the inferior and superior labial branches, and then the lateral nasal artery, as I've just mentioned before. Now we go to the posterior aspect of the external carotid artery, and we start with the ascending pharyngeal artery. And the ascending pharyngeal artery has basically two trunks and one artery in the middle of the trunks. We have the pharyngeal trunk with the inferior, middle, and superior pharyngeal arteries, and then the posterior or neuromeningeal trunk, and we go there in a minute. And then we have the inferior tympanic artery. So let's have a look at the angiogram. The external carotid artery is selectively being injected, and we can see the anterior trunk to the pharynx, so the inferior, middle, and superior pharyngeal arteries, and then the neuromeningeal trunk with the jugular division and the hypoglossal division. And usually the inferior tympanic artery arises in the middle of the anterior and neuromeningeal trunks. This is a beautiful image, and I'm using several of these images from NeuroTalks website. That is an extraordinary and comprehensive elaboration on vascular anatomy that is available. And what we can see here is that this is the neuromeningeal trunk of the ascending pharyngeal artery, getting into the inside the skull through the foramen magnum. And then there are those two divisions, the anterior division, the hypoglossal division, and the posterior division, the jugular division. And the anterior one has then ascending vessels and descending branches. And all these vessels are going to anastomose with other meningeal branches, specifically those that are the clival branches coming from the internal carotid artery. And then we have the jugular division of the neuromeningeal trunk with anterior branches that will anastomose with lateral clival branches of the infralateral trunk, and branches that go posteriorly and will anastomose with dual branches of the posterior fossa. So again, many connections between the internal carotid artery and the external carotid artery through the meninges. The occipital artery. The occipital artery is the second branch coming from the posterior aspect of the external carotid artery. It runs upwards, posteriorly, and slightly laterally, and will cross the internal jugular vein. Here we can see the anatomy of the occipital artery with a selective injection of the external carotid artery. What we see is the muscular branches that we can see here that can anastomose with other muscular branches of the vertebral artery, and also with other branches of the external carotid artery. And then here is probably very well seen because there is a fistula that is the transmastoid artery. And let me show you something that is really interesting. So the transmastoid artery has three segments: the extracranial segment, the intraosseous segment, and then the intercranial segment. And we can see it very clearly here. And it's also possible to identify the turn which corresponds to the change of the path of the artery that is related to the entering in the bone. Here again, an angiogram showing the occipital artery. And of course, because this is another dural fistula to the sigmoid sinus, we can see the same artery going into the fistula, but also some transosseous branches that usually are not present. And we can see, if I go back, we can see that this more distal aspect of the occipital artery usually doesn't have any connection into the intracranial compartment. There might be some small vessels, but they are usually not seen. But in this situation, because there is a fistula, we can see the transmastoid artery very clearly, and also these other branches. And in this situation, a very interesting finding, that is the continuation of the transmastoid artery in the posterior fossa, in the inner part of the skull, and originating the posterior meningeal artery. Usually, the posterior meningeal artery comes from the vertebral artery, and not, well, usually not from the occipital artery, but as you can see, it's possible to identify. Here, the usual posterior meningeal artery coming from the extracranial vertebral artery. And another origin of the posterior meningeal artery, this time coming from the jugular division of the ascending pharyngeal artery. So the morphology of the vessel should help us identifying which vessel it is, because sometimes they come, the origin of the vessel might change in the external carotid artery. Now the posterior auricular artery, that is the last branch of the posterior aspect of the external carotid artery. It runs posteriorly and will give the most important branch, that is the stylomastoid artery. Of course, there are also small branches to the auricle and to the scalp that will anastomose with occipital artery. But the stylomastoid artery is really important. Why? Because it will contribute to the facial nerve arterial arcade, and that we are going to go back to that arcade in some slides. So don't forget the stylomastoid artery coming from the posterior auricular artery, the most important branch, and we need to be careful with that. Then the superficial temporal artery, one of the terminal branches of the external carotid artery, and we can see that the terminal branches of the superficial temporal artery, of the STA, are the parietal and the frontal branches. The frontal branch goes to the forehead, supplying the muscles, the skin, the pericranium, and anastomosing with branches of the orbital region, and is also a potential route to the ophthalmic artery. On the other side, posteriorly, we have the parietal branch that goes posteriorly and inferiorly and will anastomose with the superficial vessels of the occipital artery and also of the posterior auricular artery. Here, a very interesting case of a patient that was where a craniotomy was performed for any other reason. There was no dural fistula before the craniotomy, and the patient develops a dural fistula at the margins of the craniotomy. And you can see that almost the entire supply coming from the STA is going into this fistula, and all the branches that we would expect going posteriorly and anteriorly are just not there. So we can see very clearly the terminal branches of the superficial temporal artery. But then we also have the transverse facial artery, that is one of the first branches of the STA, and has a horizontal path, and gives some branches to the gland, to the parotid gland, and will anastomose with the second portion of the internal maxillary artery. It means that is the muscular portion of the internal maxillary artery, and also with the ophthalmic artery. So the connection between the branch of the STA with the ophthalmic artery. And we move forward to the other terminal branches, the branch of the external carotid artery, that is the internal maxillary artery. So the internal maxillary artery has ascending and descending branches. And of course, because we are interventional neuroradiologists, we are more concerned with the ascending branches than the descending ones. So we can artificially divide the internal maxillary artery in 3 sections, if it helps us to understand and memorize the branches. And then in the ascending and descending branches as well. And I will focus mostly in the ascending branches of the first and third segments of the internal maxillary artery. The first branch is the deep auricular artery. Then we have the anterior tympanic artery. Then the very important one, the middle meningeal artery. And also important, the accessory meningeal artery. Then comes the posterior deep temporal and the anterior deep temporal arteries. Then the descending greater palatine, the pharyngeal, and the artery of the pterygoid canal. But here there is one that is important, and the infraorbital, of course, and the sphenopalatine artery. So many arteries to go through. Again, a more anatomic view of these segments, the first, the second, and the third segments of the internal maxillary artery. Let's go into the second branch, the middle meningeal artery. We have here the origin of the middle meningeal artery and the extracranial portion of the middle meningeal artery that goes into the skull through the foramen spinosum. And from in a perspective of the skull, we can see that the middle meningeal artery has an anterior and then posterior path, and then has branches into the anterior aspect of the cranium and vault and to the posterior aspect of the cranial vault. And is why that when we have a fracture of the skull, we can see epidural hematoma, because there is a laceration, or possibly there is a laceration of one of these meningeal branches of the middle meningeal artery. And of course, because it's an artery, it's high pressure, and sometimes it might be an emergency. But let me tell you about two branches that are very important, and they are not so well seen in angiograms. The petrous branch and the superior tympanic artery. The petrous branch is one of the first branches that originated immediately after the middle meningeal artery enters the skull. And the same for the superior tympanic artery. And let me show you, and let me ask you to remember again, the stylomastoid artery of the posterior auricular artery. That is this one, the stylomastoid artery. And if you remember, I told you that this is important because it's part of the facial nerve arterial arcade. And actually, the petrous branch of the middle meningeal artery contributes itself to the facial nerve arterial arcade. And this is what we see here, the petrous branch, the arcade, and then the stylomastoid artery coming from, in this case, from the posterior auricular artery. But it can as well come from the occipital artery. And this is important. Why? Because it irrigates the facial nerve, and if we embolize the middle meningeal artery very proximally, we can actually occlude the facial nerve, or disrupt the blood supply to the facial nerve arterial arcade through this petrous branch. This drawing is, in my understanding, really interesting because you can see almost all the vessels that go into the middle ear. And we have already talked about all of them. First of all, the middle meningeal artery that gives origin, as I said, to the superior tympanic artery. Then we have the superior, then we have the anterior tympanic artery coming from the internal maxillary artery. Was the first branch of the first portion of the internal maxillary artery. Then we have the caroticotympanic artery going straight into the middle ear. Then we have the inferior tympanic artery coming from the ascending pharyngeal artery. You remember, was one of the vessels in the middle of the pharyngeal and neuromeningeal trunk of the ascending pharyngeal artery. And then we have the posterior tympanic artery, which is a branch of the stylomastoid artery. So here is a network that allows blood from different systems going to other different systems. So there is a connection between the external and the internal carotid arteries, and also between different vessels of the external carotid artery from the external into the internal perspective of the skull. And you can also see the facial nerve arterial arcade. Here it is, and the contribution from the stylomastoid artery, and also the contribution from the petrous branch of the middle meningeal artery. So here everything is very well summarized. The accessory meningeal artery, the branch that comes after the middle meningeal artery. Why is it important? Because usually it supplies the infratemporal tissues, and but actually it can goes into the foramen ovale and anastomose with the infralateral trunk and contribute to the supply of the internal carotid artery, as you can see here. Why in this case? Because there was an occlusion of the internal carotid artery. So the AMA took place and contributed to the irrigation of the brain. So important to understand that if there is this kind of connections, any procedure that we might do in this region can have disastrous consequences. And then the second portion of the internal maxillary artery with the superior and inferior branches, and the third portion of the internal maxillary artery. And let's talk about this one. So this is a very distal injection of the internal maxillary artery, when we can see the sphenopalatine artery, the infraorbital artery, and also the posterior superior alveolar artery. And then this is the irrigation of the nasal fossa in the septal and lateral aspects of the nasal fossa. And we have branches coming from the ophthalmic artery, the anterior and posterior ethmoidal arteries. We have the sphenopalatine artery here well identified, and then the greater palatine artery. And these here, the Kisselbach plexus, is where usually patients are bleeding when they are having epistaxis. And this is why we can embolize the sphenopalatine artery to treat endovascularly the epistaxis. But we need to understand that our other anastomosis, especially with the anterior and posterior ethmoidal arteries, that can be dangerous, because if we are injecting any kind of particle to embolize this area, we also can retrograde fill these ethmoidal branches, and in that way reach the central artery of the retina, or also the internal carotid artery, in which case we would have blindness of the patient or a stroke. And then we, so those are the branches of the external carotid artery. And I'm going to just very lightly talk about embryology, just because if we need to understand the embryology of these vessels to understand the potential routes, anastomotic routes between these vessels and the intracranial circulation. So let's go through it very, very quickly. So we have the dorsal and the ventral aortas and 6 pharyngeal arches. But the contribution of these arches into the head come from the first 3, the first, the second, and the third pharyngeal arches. And then during the embryogenesis, during the development of the embryo, all this is going to change, and some arteries are going to reduce in caliber and disappear, and some others will appear and or change in irrigation. Like, for instance, in this situation, we can see the mandibular and the hyoid stapedial complex coming from the internal carotid artery, and then moving towards the ventral pharyngeal artery that will be the external carotid artery. And these connections, when they keep there, at least virtually, they can be dangerous and open some channels, and we are going to address that in a minute. Here, the connections between the anterior and posterior circulations as well. Let me talk about the stapedial artery very, very quickly. So we know that the stapedial artery is a branch of the hyoid artery that will disappear, will regress. And the stapedial artery has two ramus, the superior and the inferior ramus. And the superior ramus goes into the dura and also to the orbital region. And the inferior ramus goes into the maxillary, inferiorly and outside of the cranium through the foramen spinosum. So when we see the stapedial artery regressing, what we are going to see is the stapedial artery remnant that will remain superior tympanic artery that we have addressed already, and the extracranial segment of the stapedial artery that is going to be the MMA. The ophthalmic artery is also a very interesting development, and these diagrams that were conceived by James Byrne in his tutorials in endovascular neurosurgery show very clearly how the primitive anatomy is changing into an adult pattern. Here we see the contribution to the orbit of the stapedial artery through the superior ramus, and also from the dorsal ophthalmic artery coming from this region, and also from the ventral ophthalmic artery. And I should remind you that the ventral ophthalmic artery and the dorsal ophthalmic artery that I've mentioned before come from the internal carotid artery. So is why it's here in a later stage of the development, coming from different sites within the internal carotid artery. The adult normal typical pattern is the regression of the ventral ophthalmic artery, and it will come here into the more proximal aspect of the internal carotid artery, and the regression of the dorsal ophthalmic artery as well of the stapedial artery. However, this is not always the case, and we need to know when it doesn't happen. Let me tell you about, or talk about 4 situations that we might encounter in our daily practice, and we need to understand them. The first of all is a double ophthalmic artery. So we have the one that comes from the ventral ophthalmic artery in the right normal position, and the persistence of the dorsal ophthalmic artery from the infralateral trunk. And this might be an adult pattern. On the second situation, a variant, we have the complete regression of the dorsal ophthalmic artery, of the stapedial artery as well, but the persistence of the ventral ophthalmic artery. In this situation, what we have is the origin of the ophthalmic artery from the anterior cerebral artery. And in this situation, the dominance of the dorsal ophthalmic artery instead of the ventral ophthalmic artery. So we need to know all these variants because they are not pathological, but they can be dangerous. And then the extreme variation of the ophthalmic artery. It means that the ophthalmic artery depends completely on the persistence of the connection between the external and internal carotid artery, or the persistence of the stapedial artery actually. So what we see is that the ophthalmic artery, or actually all the supply to the orbit comes from the middle meningeal artery. So this is, if we go and if we are planning to embolize the middle meningeal artery for any reason, we need to see and to double check that there is no contribution of the middle meningeal artery into the orbit. A brief review of the anatomy of the ophthalmic artery. So here we have the ophthalmic artery with the central artery of the retina, the anterior ethmoidal and posterior ethmoid branches that I have already mentioned, and also the lacrimal artery coming from the ophthalmic artery. Again, from an inner perspective, the connections between the ophthalmic artery branches and other systems. Specifically, the anterior and posterior ophthalmic ethmoid arteries anastomosing with the branches of the internal maxillary artery, as I just already mentioned, specifically the sphenopalatine artery. But also, the deep recurrent ophthalmic artery, that is the connection between the ophthalmic artery and the infralateral trunk, that is actually the remnant of the dorsal ophthalmic artery during the evolution of the embryo, and also the connection between the ophthalmic artery with the middle meningeal artery through dural branches. So connections between the internal and the other branches of the internal, and also connections between dural branches of the external, distal branches of the middle of the internal maxillary artery and the ophthalmic artery. Another view, here we have the nose. So this is a lateral perspective of the orbit, and again the connections between the ethmoidal arteries and the branches from the facial artery, from the internal maxillary artery, and also from the third portion and the second portion of the internal maxillary artery. The embryology of the cavernous region is complex, and I'm going to talk just about the dorsal ophthalmic artery coming from the that will originate the inferior lateral trunk. So the inferior lateral trunk at the adult stage will give the deep recurrent ophthalmic artery, as we've just seen, that is a potential connection with the ophthalmic artery, and also with the middle meningeal artery through the artery of the foramen rotundum. And also there are branches for other branches of the external artery. So again, connections between the internal carotid artery and external carotid artery. Let's check it again. So the infralateral trunk with the anterior branch, the artery of the foramen rotundum and the artery of the foramen ovale. And all these branches will have anastomosis with the external branches of the external carotid artery. So artery of the foramen rotundum, again, why is it important? Because as we can see here, this is the external carotid artery injection, and distally there is this very tortuous branch that anastomoses with the internal carotid artery. And this is actually the artery of the foramen rotundum that usually we are not seeing it that well, but in case of occlusion of the internal carotid artery can open, and then you can see it very clearly. So the external carotid artery irrigating the brain. So is again a dangerous anastomosis. So we can say that there are no dangerous anastomosis, but dangerous doctors, that are those that don't know dangerous anastomosis. So is why this talk is about external carotid artery and dangerous anastomosis. So we are not dangerous. Why do they happen? Because of embryological and phylogenetical development of the external carotid artery and intracranial carotid artery. And the anastomotic channels sometimes are not open, but they can open in certain circumstances. And when we are doing embolization, doing some pressure to embolize and to deploy or deliver some particles, it actually can increase the intra-arterial pressure and then open this virtual anastomosis in the presence of high flow shunts, or has a collateral route when occlusion of the major intracranial arteries occur, as I've just shown some examples. So we can say that there are dangerous anastomosis in the orbital region, in the petrous cavernous region, and in the upper cervical region. The orbital anastomosis are the most important risk is the, as I said, occlusion of the central retinal artery, which results in blindness of the patient, or the embolic stroke if there is retrograde filling of the internal carotid artery to the ophthalmic artery. So how can we avoid that? Besides knowing the anatomy, one very easy way of understanding where is the ophthalmic artery filling from is to inject the internal carotid artery, inject the external carotid artery, and try to find the choroidal blush that corresponds to the filling from the ciliary and the central artery of the retina. So if we see that, we know that the ophthalmic artery is coming from the internal or the external carotid artery. This is a diagram trying to summarize all these connections, and I'm sure that they are not all here, but what we can see from here, more than knowing everything by heart, is that where are the main areas, the main risks? And we know that they are in the proximal internal and maxillary articulaterals, in the distal internal maxillary articulaterals, and also cutaneous collaterals. So the medial meningeal artery is a proximal one and has anastomosis, we just seen, with the anterior falcian artery, with the superior recurrent meningeal artery, and then all those go into the ophthalmic artery and the central retinal artery and internal carotid artery. Here is the meningo-ophthalmic artery, the extreme variation with the persistence of the stapedial artery. Then we have the distal internal maxillary artery collaterals coming from different branches of the internal maxillary artery, also anastomosing with these internal branches, internal carotid artery branches. And the cutaneous collaterals from the superficial temporal and the facial artery also going into the region of the orbit and can possibly anastomosing with these internal carotid arteries. So understanding where the regions of risk are is very important to avoid the complications. Here we have the meningo-ophthalmic artery coming from the external carotid artery and the supply of the internal carotid artery to retrograde flow from the ophthalmic artery. So important to know that this anastomosis might exist. And then the anastomosis in the region of the cavernous petrous area, coming from the ascending pharyngeal artery and the internal maxillary artery. And also several branches from these arteries can anastomose with different branches of the internal carotid artery. And all these connections might not be feasible, but if we start injecting particles, glue, those anastomoses can open, and we need to be careful and we need to identify those risks. Here, actually we can see the inferior tympanic artery anastomosing through the middle ear with the carotid tympanic artery, and then filling the distal internal carotid artery. And the same situation here, where we can see the artery of the foramen rotundum from the distal internal maxillary artery filling the internal carotid artery. So remember, because the sphenopalatine artery is a target for us when we try to embolize epistaxis, we need to be always double checking if what we are doing is not opening channels, is not opening anastomosis that will actually be very dangerous. So in conclusion, I would like to tell you, to address or to emphasize that the deep knowledge of the vascular anatomy is of paramount importance, not just for diagnostic, but also for interventional neuroradiology. And understanding the possible routes for anastomosis between vascular territories is necessary to reduce the risk of complications while performing endovascular procedures. So, after all these, I'd like to thank you for your attention, for having joined this week's NeuroTalks tutorials. And I'm sure that I will develop some other tutorials that the feedback I had from our colleagues is that these might be very interesting subjects. So definitely we are going to continue on this way. But next week there will be NeuroTalks with an expert, and we are going to talk about embolization of the medial meningeal artery to treat the chronic subdural hematomas. So I think this lecture before the next week NeuroTalks might have been very interesting. So thank you so much for being there and for watching, and see you next week. Thank you. Bye-bye.